So our learning objectives for this talk, we should understand the anatomy and physiology, which I'll review quickly, and then describe the differences between an upper motor neuron bladder and lower motor neuron bladder, stuff that we learned back in the days of medical school, and then describe the best practices for bladder management, understand the recommendations for screening, and then understanding the complications of urinary tract infections, stones, and bladder cancer. I'll spend a lot more time on UTIs. So question number one, what percentage of SCI patients have bladder dysfunction? It's high. So up to 80% of spinal cord injured patients have bladder dysfunction. And it's important because it's the number one cause of re-hospitalizations. When in doubt, always rule out UTIs. The second number of hospitalizations is respiratory issues such as pneumonia, namely aspiration pneumonia and even community-acquired pneumonia. And then third is the pressure injuries and skin breakdown. We, as non-spinal cord injured patients, do take going to the bathroom for granted because it's autonomic or automatic. So people with spinal cord injuries have to think about when, how to empty their bladders, and then it needs regular reassessments. So let's go over what micturition means and why it's important to have controlled volitional emptying and storing of your bladder in a socially accepted manner is what gives adults the ability to urinate when it's appropriate versus infants and toddlers who don't have the cognitive control of micturition. Which brings us to the anatomy. I think it's important to understand when we talk about the GU system, the upper tracts, kidneys and ureters, and then the lower tract, because we focus mostly on the lower tracts, but it's really, we're trying to protect the upper tracts from damage, because 50 years ago, the number one reason that spinal cord patients would die was due to renal failure. And then lastly, the neural control of micturition. With all that's happening, you know, it is autonomic, but there is input from the brain. And so all of this is altered when somebody sustains a spinal cord injury. Upper versus lower motor neuron. If you remember neuroanatomy, the spinal cord ends at between L1 and L2, and then below there is the cauda equina. So above the cauda equina, or where the conus is, injuries above there is considered an upper motor neuron bladder, or it's called a reflexive bladder, spastic bladder. So those are the suprasacral lesions that also lead to something called detrusor sphincter dyssynergia, where it's very coordinated. The sphincter has to open before the detrusor muscle contracts, so that urine can follow through and be excreted. When detrusor sphincter dyssynergia takes place, both muscles contract at the same time and there is no outlet, so there is an obstruction there. So that happens with an upper motor neuron bladder, whereas the lower motor neuron bladder, everything is flaccid. The bladder capacity is way higher than normal, but also the sphincter can be flaccid. So you could see it demonstrated down at the bottom. So this is a spastic bladder, and you could see how it's there's diverticula because of the high pressure, and it's a very small capacity bladder when it's filled. And this is a flaccid bladder, and you could just keep filling it. The pressures will not increase. And these two distinctions are important because it helps determine the bladder management. The goals of bladder management are continence, basically avoid incontinence to protect the skin and hygiene, and then regular bladder emptying, which is between 4 to 6 hours. You don't want somebody having to empty their bladders more frequently than that or less frequently than that. And then to avoid increased bladder pressures, this applies to the upper motor neuron bladder. And then avoiding complications and preventing complications. And ultimately, to maintain a regular lifestyle so that you're not always focused on emptying your bladder. So the best practices are either having an indwelling catheter, there's two. a Foley catheter and a suprapubic catheter. And the non-indwelling is what's called clean intermittent catheterization. And then at the bottom, I lined this out because we don't recommend condom drainage anymore, and I'll go through that in detail in a little bit. For an upper motor neuron bladder, for tetras who don't have hand function, we would recommend an indwelling catheter, either through a Foley catheter or a suprapubic catheter. For paraplegics with good hand control, we would recommend clean intermittent catheterization. For those with the cauda equina or lower motor flaccid bladder, we would recommend clean intermittent catheterization with the use of a condom drainage catheter. Condom drainage just in between, because if you think about it, the sphincter is open, and so with any abdominal movement, increase in abdominal pressure, a little bit of urine can come out. The difference between a Foley and a suprapubic catheter, it's the same system, it's just that the size of the catheter is smaller in the Foley because it's limited to the size of the urethra. Whereas the suprapubic catheter, you can go, typically we start at 16, but we go to 20, 22 French catheters, and it just helps to drain the sediment better in the bladder. There is a procedure that's involved with the suprapubic catheter placement. It's usually done under fluoroscopy through interventional radiology or cystoscopy by urology. Again, the advantages of a suprapubic catheter long-term is that it improves the flow of urine. It has also decreased episodes of autonomic dysreflexia. It frees the penis for sexual activity. Some of the disadvantages is that it can also, in the beginning, have urethral bypassing just because urine is just so used to coming out through the urethra, through the Foley. Secondly, the first change, so once the suprapubic catheter is placed, you have to wait 6 weeks before it's even changed, and the first change needs to be done by urology. And then it is reversible because the stoma closes quite readily. Like if you don't have a new system ready to be placed, sometimes the stoma could close within an hour. And then at the very bottom, don't forget a stat lock. It's a device used to secure and anchor the Foley catheter. A lot of our patients use Velcro leg straps as well, but they're not as sturdy as the stat lock. What's next? Clean intermittent catheterization. This is when someone has good hand function, they're able to do this cleanly. It doesn't need to be sterile. They start off every 4 hours, and then they can stretch it to every 6 hours depending on their water intake. The target volume of catheterization is about 500. In the mornings, it can be higher. Fluid intake has to be really managed so that they don't overwhelm their bladders. Just to be aware that overnight, because they spend most of their time in the wheelchair, that when they go to lay down, there's a lot of dumping at night, so their bladder volumes may be a lot higher. This is the most physiologic way of managing your bladder after a spinal cord injury because it allows the bladder to expand and contract. Some of the cons are the urethral trauma. Sometimes because people are insensate, they can create false passages that needs to be examined by urology. Lastly, it's also expensive. We don't recommend reusing the catheters. Unfortunately, the inside, the lumen of the catheter just cannot be cleaned well enough, despite all the attempts to clean the catheters. And then I want to say 40, 50 years ago, even people were using condom catheters after a spinal cord injury because they didn't want an indwelling catheter. Every day, a condom catheter would be on, and it would break down the penile skin. Other complications were urethral fistulas on the outside, but what we couldn't see on the inside was the buildup of pressure in the bladder. And so people would have high post-void residuals that would increase the detrusor pressure, lead to autonomic dysreflexia. And then urologists were doing what's called a sphincterotomy. They cut the internal and external sphincter so that it would just drain in the bag. But it was unbeknownst that the tone would come back into the sphincter, And people would have to do this at least 3 times before it fully opened the sphincter. So people needed really close monitoring of the bladder pressure. So we don't do this anymore. There are still a few people who've had sphincterotomies and only used condom drainage, but for acute injuries now we do not recommend this.